Joanna Joyce invited me to talk on the blood-brain barrier and also how to overcome the blood-brain barrier, as that is a problem in the treatment of GBMs, so glioma. So what I will talk about tomorrow is also give a little bit more an overview of the function of the blood-brain barrier, what are the difficulties to overcome it during the treatment, and also discuss a number of the novel developments in the field. So you have the endothelial cells that line the vessels in the brain. They are quite specialized, so they have tight junction molecules, and they have all sorts of efflux pumps, and they thereby sort of maintain all the potential neurotoxic stuff within the circulation. However, that is also a problem when you want to treat diseases that occur behind the blood-brain barrier, especially also in glioblastoma. A number of the tumors have a leaky vasculature, but the more low-grade still have an intact blood-brain tumor barrier, and they are sort of equipped to keep all the anti-cancer drugs out. So I will be discussing how the barrier is regulated and also strategies to overcome it. Yeah, so there are a couple of strategies, and some have worked and some have not. Recent development, I will highlight two recent developments I think that are the most important. So one is the generation of liposomes, and they have a sort of, in which you can encapsulate anti-cancer drugs like doxorubicin, and you can sort of have a molecule on the outside of the liposome that will recognize a molecule on the endothelial cells, and then by this recognition it will be sort of taken up and transported across the blood-brain barrier. And they have been quite successful in animal models, and they're now moving, I think now in clinical phase 2 already with these liposomal formulations. And in this sense you have a higher anti-cancer drug within the tumor, and you also lower the systemic concentration, so thereby you have less side effects. So that is one thing. And the other thing, so-called microbubbles, they are, you can inject those, and then with the use of ultrasound, these microbubbles will start resonating, and they will sort of burst. It sounds a little bit but and then you have a local opening of the vasculature, and then you can, at the site where you have your ultrasound activated microbubbles, you get a delivery of the drug into to the tumor. And this is especially for more diffuse tumors, it might be the way to go. So also this is, and you can also use MR guiding to really localize your ultrasound, the location of your ultrasound and your microbubbles. So it's technically quite challenging, but I think that is also very interesting, and they're working now towards, I think, initial clinical trials with this. So hopefully that works as well. And other things there, so you can inhibit these efflux pumps like I described earlier, and so you can inhibit them and then give a drug. You can also open a blood-brain barrier and then give the drug, but it's all really harsh measures, so to speak. Well, and also you will affect the healthy tissue, and that is the biggest problem. So how do you get your drug at the site where you really want it to be? And in the necrotic areas, you of course will have leaky blood vessels, like also discussed this morning. So then it's not a problem, but yeah, you want to fight the more diffuse tumor cells actually. I think the liposomal is really entering now the clinical stages, and the focused ultrasound in combination with the microbubbles, I think it's promising. It will be clinically challenging because you need to have the ultrasound machine, but I think a lot of people are looking into this now. So I know people in Sunnybrook are working on this. And also within the Netherlands, there is now a sort of joint effort to work on glioblastoma. So there's a new cancer center being set up in Utrecht, so university there. And they will also look into these type of strategies to treat patients. But still, yeah, in models it works nicely, but we now need to take the step to the patient. If the microbubbles are there, then that is what you affect actually. And that is one of the things that is not known. So if you do this frequently, what is actually the damage? People have not really looked into this. So they looked into models, but then they only looked like for a couple of hours or maybe a couple of days, but again, only experimental models. And for humans, we do not actually know how dangerous this is, whether it's dangerous. But then again, you know, if you have a glioma, I think you need to try everything, even if there's some tissue damage. But you need to fight it. Consider the blood-brain barrier if you're treating a patient. I think it has been ignored, and that is also the reason that a number of the trials have failed, I think, because again, you can treat the leaky vasculature and then it will work fine. But if you're really looking into ways to treat the diffuse nature of the tumor, really look into the blood-brain barrier and also consider it in your treatment strategies. Either open it or use these ultrasound or find other technical ways to circumvent it, but keep it in mind, because I think it is not ignored, but people may forget a little bit on it. And I think what we need to look into is how this blood-brain tumor barrier in the more low-grade tumors is regulated, and can we use that to find ways to maybe have new drug delivery transporters to identify them, but still it's a long way to go though. But I think, yeah, we need to look into that.